Now let's discuss about RGB fitting part 2. Yes, we're talking about general principle of RGB fitting now in this video. Okay, let's move further. What are the measurement assessment before the fit? We have already discussed in soft contact lens. Let's just go surfacely. Yes, so generally discuss with the patient advantage and disadvantages of contact lens suitability and motivation. Definitely we have to discuss about it with the patients. Slit lamp assessment for the integrity of ocular structure. We have already covered this part clearly in previous video. Tear film assessment, we have already covered it. Spectacle refraction and calculation of the ocular refraction. Definitely we have to do spectacle refraction. If there is anything, we have to do vortex distance correction. Yes, let's move further. So then, measurement and assessment before fit, we already know everything and we have discussed everything in soft contact lens, like for example keratometry, because to select BOZR. So SVID or VVID, to total diameter, select total diameter. Obviously, perpendicular aperture height or perpendicular aperture height or lid position, which is centrally important for the total diameter selection. Definitely pupil size, especially in low illumination, to find out the no matter what BOZD or FOZD. So decision of lens type to be used, decision of lens type, which type of lens um, we are going to use for the patient. We are going to insert a patient for trial lens, that must take that decision. Yes, whether it's multicarb or aspheric, especially back aspheric, toric, or when we think that spherical contact lens would not work at that particular point, we will select, we will move towards toric, or if patient want bifocal, then that's so. Then selection of BOZR is very important. Yes, how, because a lot of the time we don't have that opportunity to select different TD. We don't have opportunity to select, for example, POZD. A lot of time we don't have that. Yes, definitely if we are going to order from the particular contact lens company, in that particular case we have opportunity, but a lot of times in practically there in the trial frame set, sorry, not trial frame but trial set, basically contact lens trial set, we don't have that opportunity to select. So many of the time we have only opportunity to select or change during the fitting, especially from trial set, is BOZR. So that's why BOZR selection is central important for uh, clinical setup. Yes, so how we'll do that? So first, basically we want the apical radius of the cornea, and through the keratometry typically measure from the, definitely keratometry always measure from the very tip of the cornea, grossly around 3 mm diameter, and that gives the approximate mid value of curvature. Yes, that gives, in normal patients, it really, it doesn't matter. Actually keratometry works well, but if patient is like, for example, um, keratoconus, or for example post PK, and then we have to think about it where we need corneal topography. Yeah, so uh, tear layer thickness, so basically the ideal central tear layer thickness is 20 micron. Yes, and to create tear layer thickness 15 to 20 micron, practitioners then simply fitted the lenses 0.5 is steeper than the flat case. So that's normal, what do you call it, one guideline, but that's not it. Okay, so BOZR, what do we call, what do we select? BOZR we normally select as a flat K. Yes, that's normal in case of RGPs. So BOZD, we have already talked about it. As the BOZD increases, BOZR should be flattened to normal pore. Basically, BOZD means uh, same as the total diameter. Yes, the relationship. If BOZD increases, sorry, ZD increases, we have to increase BOZR to maintain same societal height. That's the concept. So, and the rule of thumb is very simple. If you increase BOZD by 0.5, then you have to increase BOZR by 0.05 to maintain same lens sag. The same rule of thumb applies for total diameter. If increase, we have to increase BOZR by same number. If you increase total diameter for by 0.5 mm, then we have to increase BOZR by 0.05 mm. Yes, that's another rule of thumb. So we are talking about BOZD and BOZR. It's same for total diameter and BOZR. You have to understand this concept. So the initial BOZR chosen is for always like flattest K. That's simple. What do you mean by flattest K? K1 and K2. K2 is always steepest K. That's the selection K1. Yeah, but we have to do a little bit modification on the base of other parameters. For example, so base BOZD is chosen which may turn over the total diameter. Definitely BOZD, if we increase the BOZD, total diameter also increases. Patient corneal eccentricity, higher the value of E, the flatter the compromised spherical BOZD should be. What do you mean by higher the value? Higher the eccentricity, then the flatter compromised BOZD should be used. Okay, so spherical, if cornea is spherical, BOZR is completely spherical, which means astigmatism is under one diopter. So at that particular point, we think we should use flat K as a reference. Yes. So toric BOZR, the corneal astigmatism is 1.5 or above, but normally we use, if it's greater than 3 diopter, then we will use toric BOZR. Yes, otherwise we use spherical normally in clinical setup. So for astigmatism, it's, I have already told you that for with the rule corneal astigmatism, so decentration is in upward, and that's why it's comfortable. But against the rule astigmatism, when we use spherical RGB, the displacement is sideward. So sideward means towards nose or towards the ear, basically laterally. So that will create less comfortable fitting. So that's why we try to avoid, if there is significant amount of against the rule astigmatism, and yes, definitely corneal against the rule astigmatism, we try to avoid, what do we try to avoid? We try to avoid spherical RGBs corneal lens to fit. Yes, spherical RGBs are best fitted with the rule corneal astigmatism. In astigmatic cornea, steeper corneal meridian has slightly lower E value than the flatter meridian. Therefore, toric lenses are advantageous in most cases. That's simple. If normally if it's 2.5 or 3 diopter greater sill in cornea, then it's definitely better fitting toric corneal lens. Now, BOZD rough guide is it should be at least 1.5 mm larger than the pupil diameter and average rule. So we want to cover our pupil. Yeah, larger still if the lenses are to be used frequently in activities such as night driving. Definitely, if it is night, then pupil gonna be large, and we need a larger BOZD. Yes, that's simple. Is usually fixed for a given design of the total diameter, and it's generally 1.5 1 to 1.5 mm is smaller than TD. That's good rule of thumb you have to understand. If your contact lens is, for example, 1.5 mm diameter, you roughly have idea that 8 mm will be the BOZT. That's good rough idea. If you have this rough idea in your brain, that's better. So this is good point. So selection of BOZT in toric cornea, usually smaller BOZT can increase the area of alignment and therefore improve the fit. So basically, if there is cornea is highly toric, then BOZT reduces. Obviously, that's the case with the for example, that's the case with the keratoconus. Yes, if you want to fit keratoconus with corneal lens, that's really difficult. But if you want to fit your keratoconic patients with corneal lens, corneal GP lens, then that particular lens has BOZD literally smaller. Yeah. If BOZD is reduced while maintaining the same total diameter, this results a wider periphery and flatter periphery curve and required in order to maintain the edge clearance. So definitely, if you want to reduce BOZD and remain that same TD, what do you mean by that? So optical zone is reduced, peripheral zone is increases. In that particular case, you have to take into account that what happens if peripheral curve is extremely wide, then you have to think about the edge clearance. Otherwise, if there is high edge clearance, fitting will be loose. If there is no edge clearance, for example, edges extremely touches the cornea, and it's really difficult for the patients and there is no tear exchange, and it will be catastrophic at the end. So that's why we have to understand, we have to think about both thing. If edge clearance goes up, then what happens? If edge clearance goes down, then what happens? Yes, we want optimum edge clearance. Obviously, selection of edge curve, and nowadays it's like very simple. Selection of edge curve is already made by company, which is very simple. But for the discussion, the purpose of the edge curve is to, what are the purpose? So one thing is, we don't want edge to indent it. Yes, so to prevent indentation from the lens edge on the lens movement, and assist the lens centration and provide the tear meniscus and improve comfort. For comfort, is most important. Okay, it's not important, it's most important, because whenever students think about discomfort, they think like corneal lens, uh, just go into the cornea and that will create discomfort. No, this, the main reason of discomfort is when this edge interact with upper lid conjunctiva. So that's, there is a discomfort. Okay, the main reason for discomfort is upper lid conjunctiva interact with this edge of the lens. So their discomfort is, there is the reason of discomfort. But to improve comfort, we have to think about lens edge design. Lenses design also help in the tear exchange, also helps definitely tear, whenever there are tear exchange, there is a definite lens movement. Yes, these three things go moves with one another. So selection of edge curve, it should be what it should be. It should be adequate enough and encourage a good retro tear flow. We want tear flow, isn't it? So adequate enough to allow the lens easily removal. If, suppose example, if edge is attached strongly to cornea, what happens? It's really difficult to remove contact lens, isn't it? So we want it's adequate enough so that we can remove contact lens easily. Patient can remove contact lens easily. Not to be excessive, to allow lens movement into the perilimbal area. What do you mean by that? If edge clearance goes up, then there is a high lens movement. If it is too much, then there will be a bubble. If it is too much edge clearance, then it will definitely pop out from the eye. Yes, not to be excessive to cause edge awareness. Definitely, if edge clearance is too much, then edge awareness will be there. What do you mean by that? It means by interaction with lead, that edge interacts with lead. Yeah, definitely. I have taken this picture from, I think, that book, Efren. Yes. So now selection of total diameter. So too large total diameter may allow the limbal bumping on the ocular excision, and in case moderate astigmatic cornea may precipitate the need of astigmatic fit lens due to the excessive edge clearance along the steep meridian. See, why corneal lens? We don't want too much, too large, like for example extreme large, like limbal 11. First, we don't want cornea to injure limbal one. Then we don't want, see, when there is a junction between cornea and limbus, so there is a little bit not a smooth area. Yes, it's like transition. So at that particular transition, there can be problem if total diameter of the corneal lens is, like for example 11.7 or 8. That's why we go 9.4, 9.5 up to 10. Yes, so most corneal lens now have total diameter roughly the maximum 10.5, but 10 mm is my favorite. Yes, so normally what this picture show, can you see? I have talked about this. If the inferior lower lid is not particularly at the cornea, like if upper lid fall down, if both lid makes eye smaller, if lower lid moves upward. Yes, it's like, so that's totally the relation to the position of the eye. So what we do in that particular area, it's like if lower lid is a little bit lower than the regular, we need a little bit larger total diameter. Yeah, So that's how it goes. With the lead position also, we think about the total diameter of the contact lens. So selection of the intermediate curve. So what do we do about intermediate curve? What do you mean by intermediate? One is base curve, then first periphery curve, then second periphery curve, then third periphery curve, and so on and so on. Or the asphericity. So what do we mean by intermediate curve? Means the provide the transition between BOZR and H curves. So after BOZR there is first curve, second curve, third curve. That all we know is H curves. Yes, each curve should have minimum width of this. That's important for you. Yes? Minimum of width 0.25. That is 0.5 mm between the BOZD and B peripheral zone diameter, with a radius that is between BOZR and H curve. What do you mean by that? Means whenever you select base curve, for example, let's take an example of 8 mm base curve, then first periphery must be flatter, isn't it? 100% must be flatter. It must be around it. Let's take an example. Then second periphery must be flatter than first periphery. Let's take an example 9.2. If we choose third periphery, it must be flatter, like for example 10 radius of curvature. Why? Because cornea itself from center to periphery flatter. So that's why we want, if base curve is 8 mm, then we definitely select first periphery curve 8.6, whatever, a larger number, because larger the BOZR, larger the radius of curvature means flatter, because we want to follow the corneal contour. If we do, for example, let's take an example, 8 is a base curve, and then first curve, let's take example, if it is more curve like 7, what do we call this kind of contact lens? We call reverse geometry. Yes, in orthokeratology we call it reverse geometry. Why reverse geometry? Because what is on reverse, what is regular, is always like cornea. Center is steeper, as you move from to the periphery it becomes flatter, 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 flatter. Yes, and when base curve is flatter than the first curve, it's called reverse geometry. Just remember why we use that word, reverse geometry. Okay, so that's what the second line means. Okay, third lines. Commonly, only one intermediate curve is necessary, but if there is relatively large distance to be between the edge and the BOZD edge curve, more than one curve may be necessary for follow the corneal contour. That's what I am talking about. Following corneal contour is important. That's why first curve is flatter, second curve is more flatter, third curve is more flatter. So it's depend upon the design, how much curve they have to manufacture. Yes. So front optic zone diameter. I have already talked about front optic zone. What is front optic zone? It should be larger than BOZT and roughly 0.5 mm larger than BOZT. Must cover the pupil constantly throughout the lens form associated with blink. So optic zone diameter, no matter what, front or back, we want it to cover pupil completely and all the time. Okay, so adequate optic zone will cause flare, especially when pupil dilates at dark. Definitely. So reduces the front optic zone diameter, reduces the central thickness, and better oxygen transmission. One of the factor, when we try to increase FOGT, it means thickness also increases. That's one important point. For plus lens, central thickness. For minus lens, edge thickness. It's very important you understand this concept, no matter what front optic zone or the back optic zone. That's the concept. Okay, fine. So front optic zone diameter, for example, see, if it's 9.8 mm total diameter, it's 7 diopter power plus. So FOZ is not reduced. What happened? It's like 0.41 mm thickness for the center. But what happens when from uh, it reduced to 7 mm? All parameters are same. Thickness reduced by from 4.1 to 0.26 mm, which is nearly 60% thinner. Yes, as compared to, so not 60%, not 60%, but yeah, 60%, from 100% to 60%. It came to 60%. So it's very important. Yes, whenever we reduce FOGT, so that's why one of the reasons, that's why whenever we need, like literally need very high power, then what we do not reduce front optic zone diameter. We generally, what do we do, we do use lenticular design, isn't it? That's why. Okay, because whenever you reduce front optic zone diameter, then you reduce thickness, and definitely it's very important. Yes, we know decavity is centrally important, and we want t to be less, we want thickness to be less, that t to be less. Yes. Okay, front optic zone diameter, except in low power, most rigid lenses are lenticular, so as to reduce thickness and weight for the better oxygen. That's what I have already talked about, that why you need lenticulation if there is high power. For example, what do we take example? For example, aphakia. Yeah? So negative carrier and positive carrier, what do you mean by that? Whenever we talk about lenticular lens, we talk about carrier, because the central optic zone, then we have carrier. So incorporate occasionally in order to increase lead assessment. If we use negative carrier, means thickness at the periphery. So if you have thick edge at the periphery, it will definitely help to lead to attach at that particular contact lens. Yes. So negative carrier will definitely help for the lead attachment philosophy. And positive carrier. So what do you mean a positive? So tapered edge design. Yes. Used occasionally to discourage the lead attachment. Exactly another thing. Because whenever you use positive carrier, so lead attachment will not be there, because thickness of the edge will definitely go down. Yes. So that's two things. Yeah, you have to understand what is positive carrier and what is negative carrier. That's very important for your understanding of contact lens, and like flow, how to do, what are the corrections we can do for high riding lenses, for example, or for low riding lenses, for example. Yes. Okay, so central thickness, let's talk about it. If lens made too thin, not only is there greater risk of breakage, but also the lens tend to flex. That's important. We are walking away from the thick lens because we think, oh god, thicker the lens, lower the decavity. But at the same time, if you want to make too thin, the lens may tend to flex, especially on the astigmatic cornea. So what will eventually lead? Eventually lead to residual astigmatism. That's what we strictly don't want. Yes. So it's better that our contact lens thickness must be optimum. It should not be thick so that decavity hampered, or should not be thin so that it itself flex and create residual astigmatism. We don't want both thinner or thicker contact lens. We want adequate contact lens thickness. As the flexure is a function of lens thickness, it is worse with the low minus power lenses. Definitely, it's worse, yes, with low minus power lenses, because minus power central is thinner. If it is more thinner and then low power, then there will be a problem. For a given family material, flexure tend to increase with the decay. It's always that, like with the greater the decay, greater the chances of flexure. Greater the decay, greater the chance that material decay rapidly. So that's a lot. If there is necessary to increase the lens thickness with a high decay, so that's why in high decay material always tend to be softer than low decay material. It's another important point. So that's why in case of high decay material, for handling purpose, yeah, definitely we don't want to it to be flex. So we try to make high decay material a little bit thicker. So this is rough guideline, definitely taken from the Efron book. See, so this is the thickness, and one of the let's see, -1, then 0.18, -2 central thickness, -4 central thickness, -5 or greater central thickness. This is very important. See, add 0.02 for corneal astigmatism greater than 2. If there is astigmatism, then it suggests to add a little bit corneal central contact lens thickness, because the corneal astigmatism greater, chances of contact lens to flex is greater. Yes. So let's stop here. It's already 25 minutes, and then I'll continue from here onward in my next video, which is part 3. Yes, part 3 continue from here. Okay, bis dann, tschüss.